Good morning and a very hearty welcome to Bonitas House Call here on the SABC 2. Mabandla kamjobana kandaba. Solomnyama wendlela zimhlophe ngithi kunina nonke ebukhosini. I'm Dr Victor Ramathesele. Nina nongilukisetsana ngakahlu. Ohlelweni lakho oluhlakahlosile. Oluza njalo ngomgqibelo uma ligamenxe elesishagalombili ihora. Now today we are going to look at one of South Africa's biggest healthcare challenges, and one around which thankfully we've begun to turn the corner. And in fact, as we put it, re ka jeno re tletla tsepamisa maikutlo a rona le go bea monwana go lefulena la HIV kapa kokwanahloko e bitswang mosollahlapi. Now we've invited into the studio two doctors from KZN, Dr. Hlova, who's a dermatologist from the University of KwaZulu-Natal in Durban, Takwini, as well as Professor Anissa Mosam, who's also a dermatologist from that institution. Now, they've just released this beautiful book that provides some guidelines on how to recognize, diagnose, and manage skin diseases in patients living with the HIV virus. Now, don't forget to call us on 011 285 6050 with your questions and comments on skin disease, or you can send your SMSs to Bonitas 33723. Ladies, thank you very much for joining us this morning. I had the pleasure of going through this book, which thankfully you sent to me a few days ago. Now, Dr. Hlova and Professor Mosam, can we start with you? Because she's been on House Call before, so she's much more relaxed and maybe saying, now, this book, what inspired this book?
I think it was the fact that, HIV has, exploded really in our country, and at least 9 out of 10 patients were presenting with skin disease, and we had people serving at the coalface who weren't really prepared to deal with skin conditions. As you know, we only have limited number of dermatologists in the country, and all of these patients were not going to be able to access a dermatologist. So the idea was to make a user-friendly atlas that specifically targeted dark skin type, because most of those that have been produced elsewhere in the world were on Caucasian or white skin.
That when we were trading, the books that we used were mainly for light skins.
Absolutely.
So not much was written around the dark skins,
yes,
which is what most of us are seeing in practice.
Yes. Yeah. And skin conditions look completely different. So in the rest of the world, there were many atlases which were photographed on white skins, and also which looked at skin disease etiologically. So they looked at causes rather than what the lesions looked like. So that inspired us to allow.
So it's geared towards nurses, it's geared towards general practitioners, and so they can refer to it if they are not certain. Because I see, because it's pictorial also, so it does help with the diagnosis. And we do also give some guidelines on how to manage some of the skin conditions. Now, she's saying there are not enough dermatologists in South Africa. Why is the reason?
I think it's...
If there's one condition where you want to be called for an emergency, very, very unlikely is dermatology. So
that is true, Vicky. In fact, the reasons are multifactorial. Firstly, the restriction in the number of posts that are there for training dermatologists, problem with funding from the Department of Health. So, recently, we've actually had a cut in the number of registrars that we can train.
Is that so?
Yes, hence.
So we must make a plea to the policymakers that they need to create more posts for training dermatologists, because this is postgraduate training.
Yes, yeah. And also I think it's important for people who come into dermatology to realize that dermatology is not only about cosmetics. Dermatology, particularly in sub-Saharan Africa and in the third world countries, is about treating infections, tropical dermatology, HIV-related conditions. It's not about treating wrinkles and botox.
It's not about acne and wrinkles.
Of course,
so
acne
there's a serious side.
It's a serious side, yeah. And we want people to train and go out to the rural areas and provide services where there are none, because people tend to congregate in the urban areas.
Now, where's that clinic? Because you guys in KZN, you've done tremendous work in working with the private sector and establishing, a very fancy, that skin clinic that you have here. Tell us a little bit more. What happened there?
Well, you know, we realized the need to create a good ambience for our doctors
And this
and
looks
our
beautiful. I
nurses.
mean, you'd never guess that this is a public
It's a public
facility.
hospital. Yeah,
Well
actually,
done, you guys.
this work started last year in September, and we sourced private designers, Vuyo, Lerato, and they actually assisted us with the renovations. We also sought sponsorship from the private partners. Pharmaceutical companies were a great resource in terms of funding. Private dermatologists were very helpful, and even the staff in the department, people like Prof. Mosa, myself, and other doctors in the department, and patients donated paint, donated their time, and we raised up to about 500,000 rands from, and this is what we call the public-private partnership. And we're able to renovate the clinic, you know, to create that wonderful ambience for the nurses, for the doctors, and for patients alike. So it was really, it's really a great success story.
Well done. Well
Yeah,
done.
thank
Now,
you.
let's come back now to the subject of this book. Now, the immune status and skin conditions. What is the relationship between the two?
I think the two are inextricably linked in terms of CD4 cells and T cells that are affected in HIV. These are resident cells within the skin. In fact, Langerhans cells, which are, the most peripheral outpost of the immune system, are in the skin. So when somebody is affected with HIV, these cells are affected in the skin as well. And certainly, the skin may be one of the first signs of involvement
so it is for
in an
this reason
HIV
that you
positive.
guys encourage men to remove the foreskin, because you see the skin in the foreskin being something that can actually affect the HIV virus quite
absolutely,
easily.
and also for transmission
Yeah.
purposes. So, circumcision is an important preventive tool for the transmission, in HIV. So certainly one can assess the stage of HIV by the skin, and depending on what conditions this patient presents with, we can tell whether they really are seroconverting, whether they're in the early stages of HIV, where the CD4 count, or these are basically the soldiers, that actually prevent against other infections. When these are going down, one then presents with more severe skin conditions.
Now, she talks about when various stages of the HIV disease, that skin conditions become very important in assessing. Now, she spoke about seroconversion. Now, do you want to explain what seroconversion is and what kind of skin conditions are maybe common during that phase of the disease?
Yeah, seroconversion period is when one gets infected with the HIV virus.
When the virus begins to get into the blood
after having be it during sexual transmission and stuff. So what actually happens, 25% of patients will actually present with the symptoms of seroconversion. Most of them become asymptomatic, meaning you won't even feel anything that you've got HIV. But the way seroconversion presents, it presents like a flu-like symptom. You get headaches, sore throat, muscle pain, joint pains, maybe headaches. It's very non-specific, very non-specific. And as I mentioned, a very small percentage of patients will actually present with a seroconversion illness. In addition to these systemic symptoms, the flu, the headaches, and lethargy, weakness, you may also get a skin rash, which may present like measles, the old measles that children have, yes, just a red rash or generalized rash, which is transient, and it will, disappear after a while.
I see. And there are also skin conditions that are typical of advanced AIDS, as it were, full-blown AIDS.
Absolutely. So, the seroconversion illness is very non-specific, and even at that stage, you won't be able to diagnose it if you just do an HIV test. You need to do a PCR to be able to diagnose. But if that patient had a risky, episode, a blood transfusion, then that might be a clue to it. So absolutely, in the advanced stage, at the other end of the spectrum, one might get disseminated fungal infections, like histoplasmosis and cryptococcosis. And those are the AIDS-defining conditions. So that basically tells you patients have got full-blown AIDS, conditions like Kaposi sarcoma. And those are important to diagnose because it means patients need to get onto antiretroviral therapy immediately.
Okay, because
So
some of
that-
those skin conditions
Absolutely.
will determine the advanced stage of the condition, or at least the condition at which point you would want to introduce antiretrovirals.
Antiretrovirals, yes.
Now, how do you classify these skin conditions in the HIV disease spectrum? I know you could classify them by anatomy, that facial conditions, trunk conditions, maybe conditions in the extremities. But how do you classify them?
Good question, Vicky. I think the simplest way for the public is you have early disease. Okay, you've got the seroconversion, which you've mentioned, the rush that you can get. Then you've got early disease and you've got advanced disease. And in terms of the stages, then you've got the different types of infections. You can get infections, be it viral infections like herpes zoster, chickenpox, Molluscum, contagiosum. You can get bacterial infections like staph infections. They cause boils, they cause cellulitis, and you get infection around the hair
Abscesses
follicles and
stuff like that.
abscesses. Then you have inflammatory conditions. Now, it's important for the listeners and viewers to know that these conditions do occur in normal people. It's just that in HIV, they tend to be more severe, they tend to be more recurrent, you keep getting them all the time, and they become difficult to treat. So the psoriasis you can get, which is quite common, seborrheic dermatitis, which is a type of eczema. In fact, in a study that we did with Prof. Mosam, looking at the conditions in HIV in KZN, we found that the top 5 conditions that were common presentations early on in HIV was herpes zoster, which is shingles, by busy
We'll come back to that. We'll come back to that. So don't spoil the fun. Yeah,
Yes,
okay. It's herpes zoster, yeah.
And then it's seborrheic dermatitis. Now, most people present with sebderm and they think they've got dandruff on the scalp. They say, Doctor, I've got so much dandruff. And in actual fact, that is an early manifestation of sebderm. And they get rash behind the ears, under the breast, and on the groin. And the third one is psoriasis. And I want to add on to this. Psoriasis is common in Indian patients and Caucasian patients, but not so common in Africans. So when you see psoriasis in Africans, it alerts us.
It alerts you that there could be
related to HIV.
Yeah.
And then, of course, other skin conditions like people will lose weight, they will have thinning of the hair, they will also have pigmentation, they just get darker. But having said that, not all causes of darkness are due to HIV.
asibambe lapho but asifuni ukuthi umuntu athi uyabheka umuntu abesithi hawu
That's
waqale
the
lona nje
thing.
emlonyeni yini ngathi
Yes.
usonengculaza. We don't want that level of irresponsibility.
Absolutely, yeah.
As they say, the eyes are said to be the window of the soul, but we also know that the skin says a lot about our emotions and well-being. Now, we'll continue our discussion on the HIV and the skin. Mogaiso ga wa latlhega le seng go gorogile ka tlhabanalo mo Bonitas House Call thulaganyo ya gago ya mamorate mo mosong wa la matlhatso ga gorogela go ganagana le rona ka tlhabanalo mo nomorong ya 011-285-6050 kgotsa mafaratlhatlha SMS mo Bonitas 33723. We are now joined by Anonymous from Pretoria. Thank you for joining Bonitas House Call. Good morning.
Morning.
Yes, ma'am.
Yes, my name is Anonymous from Pretoria. Can I speak to my own language?
Yes, bua ka language ya gago mma.
Okay, can I tell you, I've got a brother, only 17 years. He was diagnosed since birth. So we all found out when my mother was passed away, when she was the age of 3 years. Okay, only this thing, first the doctor Nabari has a massive treatment, Nabari ring when it's growing on both. It's like what the gloves, something like that. So, Mama Toko, it was a ringworm or something. First, ringworm, good doctor, ringworm. So, this thing I fall, Bamufa treatment, then it's to say, no. So, I came to care of family thing. I'm a regular episode A. Episode wise has a carrying at a bit, but that thing doesn't go away. In Mama Toko, both hands, and then if you feel I write because what was called Bamutaramba, was called this thing, Mama Toko.
Yeah, Loma. Do you know if you are?
Yeah, it's itchy. It's itchy. Sometimes I be itchy. But it will occur it's a ringworm or something. After how well about no, the treatment wrong, after ringworm, the doctor is working.
What better come to or Utana school?
You want to school or grade 10.
The skin condition are so difficult to discuss. Also, the actual the actual condition. You know, re tla bua mo until the afternoon. It was easier. Even but be that as it may, now, in summary, 17-year-old, school-going age, doesn't work, has got, you know, a rash in both hands, almost like he's wearing gloves. And it's been going on for quite some time. They said it's a ringworm. They are giving treatment, and it's not improving. Could it be a fungal infection of sorts?
I doubt very much if it's fungal infection, usually it's one hand that's affected, and it won't really involve both hands extensive like that. So
if they were working, I mean, it would raise a suspicion of a contact dermatitis of
could
sorts,
be
where
eczema
there's something that is constantly in contact with the skin that the skin is reacting to. But it doesn't sound like. But you know, it's a pity that we really cannot do much except to suggest that she must go and see a dermatologist.
Absolutely.
But I think those kind of patients should really insist, even if they go to a public sector. If they went to King Edward, of course, I mean, it would be easy because they would find you guys. But we can only hope that in the public sector we do have enough dermatologists that could deal with the problem. Now, let's see some of the conditions that that we find that are common in HIV. Now, this particular condition that we're going to show now is the one that is called what, Dr.
Yeah, even though the picture is not so clear, but this is what we call herpes zoster. Shingles,
herpes zoster.
Yeah.
Iband. Because it usually affects the dermatomes. It usually affects. It runs where nerves are.
Yes.
Now let's explain shingles. We know what it is. Basically, what happens is that as a young person, at some point you get what? You get a chickenpox infection.
Yes.
And when the chickenpox finally heals, the virus goes and sits in the nerves around the body. It could be the nerves on the face, it could be the nerves here, around the chest, and in other parts of the body. And it sits there and it doesn't cause problems until and unless your immunity goes down. And when that immunity goes down, and then that virus comes back, but now it's no longer the chickenpox that it was. It now presents as a herpes zoster or a band. As we call it. Now, as long as I learned out, kuyaziwa lokushini ukuthi uyabona uma unebhandi, Dr. Love. Uthi le bhandi lezi baniza ngaphambili, elinye liza ngasemuva. La lihlangana khona ibhandi, ayaduma amabhasi. That is not true. But how common is ibhande in people who are infected with the HIV virus?
Yes, ibhande, as in shingles, it's actually one of the commonest presentations of HIV. And it tends to present in the early stages of your HIV.
The early stages of the
when your CD4 count is still high.
Okay.
But I want to emphasize this. Having ibhande or shingles does not mean you've got HIV. Ibhande can occur under 3 circumstances. Firstly, in elderly people, okay, because the immunity tends to go down. Secondly, people who've got cancer, okay, whatever cause of cancer. Thirdly, people who are on immunosuppressants, if people are taking certain medication, that will suppress the immunity.
For a variety of reasons, especially your autoimmune conditions where the body creates antibodies that fight against itself, like rheumatoid arthritis and like SLE or lupus. Now, in those cases, you need to give them medication that is deliberately going to reduce their immunity. And when that happens, unfortunately, if they say the virus is
so I don't want people to leave here with the perception that ibhande, when you have ibhande or shingles, that means you've got HIV.
How do you treat herpes zoster or ibhande or shingles?
So I think the main thing is to treat it very early, usually within 72 hours. And with antivirals, that would be the most specific,
it's painful,
effective. It's very, very painful. And just to add to what Dr. Glover was saying, in patients, we expect it in elderly patients. So over 50, it goes on with each decade, you expect it in elderly. So when you get it in patients younger than 50, then an HIV test is actually mandatory, unless they have another reason, to present with herpes zoster. So basically, the treatment would be antivirals. That's the best treatment, acyclovir for at least a week, with analgesia. And if it's treated early, it means the pain that can occur afterwards, which we call post-herpetic neuralgia, is lessened. That's important.
Now, I remember fighting with an elderly patient of mine because I test anybody who comes in with ibhande. I do an HIV test, even if you're 90 years old. I don't care. Now, I do fight with the elder. No. I must exclude. Do you think I'm exaggerating in insisting that everybody who presents with IPANDA must at least have an HIV test?
I think emphasizing what Anissa just said, in that if you're less than 50 and you've got HIV, I think it's mandatory, it's compulsory you do an HIV screen. But you never know. If in addition, in an elderly patient, you've got shingles and other indicators, the patient has lost weight and other manifestations, then I think
But you said it could happen early in the disease, so they've not lost weight by that time. And
no, I'm talking about an elderly person who has shingles and other associated features. Then you combine and then,
Anonymous, you are joining us from Tembisa, West Mambisa. Thank you for joining Bonitas House Call. Good morning.
Morning, how are you, sir?
Good yourself.
I came to Kaposi last day,
Ebolela Spedi Khosh, ha o ne molato.
ke na le bothata motse. Bothata ja ga ke le ga ba le ntse ba re ke le panta.
Okay.
So le panta le run up to 5 years now. The way because I could wait to look for but I fall. That's so and I get play rush la luma haholo.
O di ile test ya HIV?
Ke le test then ke nka treatment.
O nka treatment. O rile la ba gona le banta le ke moka la fola maro sentse o kwa pain ene le go tlhotlhona mo di shotse be di hlaileng gona ankere ke yona ntho e tlhalosang.
Doctor is on the look fela but a treatment one person I wasn't referred. This for 2 years guy tholang.
Okay, go re kile pro. Theeletsa ge batla ra ba putsiso bo mmabake ke mkona mmereko wa bone ba o tsebang he botse ke di professor tsa bona boletse go relang ka bona. Post hepatic pain, she had the gentleman tested positive for HIV. He's taking ARVs. He had IPANDA or herpes. It healed, but he remains with constant pain and itchiness around the area where it was. You guys call this post-hepatic neuralgia or whatever complicated term they call it. What treatment is this supposed to be on? Because all the doctor said was that, hey, bro, take your time, this thing will heal, which is not good enough.
Yes. In fact, as Anissa will also add on, we always emphasize to general practitioners and the nurses in the clinic that when they see patients with herpes zoster, they must always call them for follow-up, 6 weeks after treatment, because that's the time when you get the post-herpetic neuralgia. It can be challenging to treat, and it can manifest with different symptoms. And as the patient has mentioned, it could be an itchy pain.
Is it expensive? Why are the doctors not putting them on that treatment?
It's actually not expensive. Some of them are not aware of the complication.
Or the doctors themselves.
The doctors
so
themselves and the nurses.
What exactly do you give them?
We give them triptanol and 25 milligrams, and we increase the dose depending on the response. We sometimes give topical anesthetic, sometimes we inject the area. And also, I want to add that sometimes in the past they used to give Tegretol. And Tegretol, we shy away from it because of the drug reactions. I want to add this as something that should not be given, because patients with HIV have a high risk of developing drug reactions.
Okay. Bro, ka bona ka mothebisa o kwela e wana treatment e tshentse be we kreile doctor tshentse ba file yona ona le cream o tshentse wa itshasa mola di dipilisi zo tshentse di doctor di bitsitse ka mabitso mo ke tshepa gore go nke tsere pene wa ngwala o bela kwa clinic go gopela doctor gore a o fe di tlhare tsere. What condition is this now, Professor Musang?
Okay, this is Molluscum contagiosum.
Molluscum contagiosum.
Yes. Okay, so they basically,
it's a
viral infection.
A lot of people get this, especially if they shave using the razor, don't they?
So that's a different condition. That is folliculitis, when they get little pustules. But these are solid lesions. It actually is a condition that's very common in healthy young children, who don't have any specific immune deficiency. And if you see it in a child with a few lesions, there's no need to worry.
But if you see it in an adult like that?
But if you see it in an adult, certainly one is worried. Or if you see it in a child and you've got numerous lesions or giant lesions, then one should be testing them. Okay. One can also see these in atopic children, because atopic children are using topical steroids, so they get some...
are those children who have all manner of
eczemas, yes, the eczemas, so they're using allergies, topical steroids, and they're also prone to getting molluscum contagiosum, yes.
Well, there's no doubt we're going to go to while as South Africans or South Africa has a high rate of HIV infections, we have also the biggest HIV treatment program in the world. And this has led to many people living with HIV infections and dealing with it like any other chronic conditions. But we still want people to focus on safe sex and healthy living. We'll continue our discussion on HIV and the skin when we return. Welcome back. You're watching Bonitas House Call here on SABC2, and today we are discussing HIV and the skin. Now, I'm going to go through this book with the doctors, Dr. Hlova and Professor Molluscum here, and then they'll be telling us exactly what is content. Let's see the first one quickly now. What condition is this, Prof?
Okay, this is Kaposi's sarcoma.
Kaposi's sarcoma.
Yeah, so it's
now, sarcoma is cancer, isn't it?
It is a cancer that patients with HIV/AIDS get. It was a condition that it's common also in Central Africa, even in patients who are not infected with HIV, very common in male patients. But we are seeing now the endemic form or the epidemic form, which is associated with
lots of people with HIV presenting with this type of
we
cancer.
do have, yes.
It happens at what stage of the condition?
Usually it's an AIDS-defining condition. So patients who have it actually have got full-blown AIDS.
So it means if you know yourself to be HIV positive, and you suddenly present with this type of cancer, then we know that we are now in full-blown AIDS.
Absolutely.
In other words, or it can be defined as a stage 4, as you guys say.
It's a stage 4 condition.
Advanced HIV disease.
So it's something that really warrants antiretroviral
This
therapy.
one?
Okay. This is a condition we call papular eruption of HIV. It's a very common itchy condition seen in HIV-infected individuals.
Dr. I've seen this on the beach, that's for sure. I mean, this is, I'm definite about it. Is it a condition when you see it in a young person, you worry that they could be having HIV positivity?
Yes, I think I would worry. And as Anissa has mentioned, it also resembles another condition called eosinophilic folliculitis, where you get very itchy lesions. It almost looks like you've had insect bite, mosquito bites. And it occurs on the face, on the upper trunk, and upper limbs. It's extremely itchy. And when it heals, it leaves scars and marks. So it's something to worry
This one?
about.
So this is psoriasis. This is
this psoriasis?
It's psoriasis, but
looks scaly, eh?
What happens is we see severe psoriasis in HIV, and then it covers from head to toe, and that we call erythroderma. So where patients come in basically red and scaly.
This is the one that they're describing. Now, this is a very common condition even in people who are not HIV positive.
Well, psoriasis is common, but we don't often see this extent of psoriasis in patients who are not HIV positive. It will be localized to like the elbows and the knees and the scalp. But when in HIV, we see it become unstable and get out of control.
Now, psoriasis is not common among Africans. We are taught maybe things have changed.
No,
so if you see it in an African person, you worry about possibilities of HIV.
Yeah, I'm impressed. Your dermatology is very good.
You guys taught us. I mean, it may be many years ago, but if you see these things, you refer, and then you send to dermatology. People don't realize that. As family practitioners, we actually learn from the patients that we refer to you guys for as long as you report back to us and say, what do you refer to me? This was the condition, this is how I've treated it, because it is an ongoing learning process. Now, how do you treat that? Suffice to say, it is a condition that might indicate positivity, but how do you treat it?
Okay, that particular slide that you showed with the sores on the legs, that is called PNT. I know that's Greek to everyone, but it's a type of skin TB, which occurs in patients with HIV.
So it's tuberculosis of the skin.
Yes, tuberculosis of
common
the skin
among people who are HIV
patients who are HIV positive. So even for us, it may be daunting in that we can confuse it with other conditions. So we almost always have to do a skin biopsy, meaning we take a piece of the skin, send it to the pathologist to look at it and tell us, yes, it is TB, it is skin TB. And then we will start the patient on anti-TB treatment and do chest x-rays and look for TB somewhere else.
I see.
And they have to be on the full 6 months.
Now, just before we look at this picture, now let's go back to that Kaposi sarcoma a little bit. So how do you diagnose it? You do what Dr. Hlova says? You take a piece of that skin, send it to the laboratory?
I think that needs to be done, but it's quite typical, the skin lesions. So people looking at it, not necessarily dermatologists, even just healthcare professionals are able to diagnose that because it's violaceous, it's purplish, and it occurs in certain areas, like specifically the legs, the palate as well. It can be very, very easily diagnosed. And yes, we do have to do a skin biopsy. But what I want to mention about Kaposi sarcoma is because it affects the legs, very often we have patients coming in thinking that you know, there's another reason for it. And basically patients come in and think they've been bewitched, or, you know, there's also very much...
Or because of weight.
Yes, they come in, they say these elephant legs.
Okay.
Yes. So very often patients might have visited a traditional healer before they've come to us. Yes.
Okay.
And, you know, we often see it on the legs, and they develop these lymphedema, sort of swollen legs, or what we call elephant legs, because it affects the lymphatics.
Treatment. It's a treatable.
Yes.
For cancer,
it is, absolutely, it's treatable. So in the early stages, we'd give them antiretroviral drugs, and that helps to boost the immunity. And in the later stages, they absolutely would need chemotherapy or radiotherapy for it.
Do they respond well to chemotherapy and radiotherapy?
Yes, yes, they do. In fact, Kaposi sarcoma, it's Prof. Mosam's pet subject. So she knows more about it more than I do. But just to add on to that, the point about traditional healers, I think it's important, as you mentioned, that patients present early, because the success of treatment is much more enhanced if the patient presents early. I mean, as much as we respect cultural beliefs and traditions and traditional healers, but there are certain things that need to be seen by doctors, and Kaposi sarcoma is just one of those things. Don't wait for your leg to get swollen, because at that stage there's not much more we can do.
I see.
Yes.
So you find a lot of people go to the traditional doctors first when they have this, and we said earlier, because it happens in their legs, there's a view that they could have been bewitched, or they crossed something that was put, and that delays the proper treatment. And you are saying the success to treatment of Kaposi sarcoma is actually early treatment. So you want to encourage people that if you're HIV positive and you have legs that look like that, go to the doctors as soon as possible, because it means your disease is advanced, and it means if you don't treat it early, the repercussions may be too ghastly to contemplate. Yes. Anonymous, today we are just joining us from Soweto. Thank you for joining Bonitas House Call. Good morning.
Good morning, sir, guys.
Good morning, ma.
Ke teng papa ke go botsa mantira le ngwana go gaene bona le diso mo tlhogong diso ka teng o ile tleliniking ba mo fa dilo tsa o tlhapa mo treatmenting, but then ba mo fa dilo tsa o tlhapa, then le mo morago mo mokokotlong di tswa metsinyana diso tsa teng di boladunyana, so a ke tsebe gore re ka mo thusa jwang, because clinicing o ile several times ntse ba mo fa the same medicine but a di fele.
O itse o na le ngwaga mo kae? O itse o na le jara tse ka motho?
O na le 15 years.
15.
Yeah.
Okay. And ba itse ke diso fela ba mohlaba ka treatment ha ba hlalosa le hore what
yeah, that ba mo checka dio tse dingata re mo local clinic, then ba mo file fela dijo tse tsa o tlhapa ra boela gape ra ba bolela right, there's no difference at the same. Ba mo fa the same medication gape, but still dijo tse di le fela jwang.
Wa itse keng if o no tseba medication ba mo fileng yona, at least it would give us an idea ya hore ba nagana hore
the medication about Fanyana, Bona, Barabanyana, Bakuta, Miri, Strate, Baka, there is this thing about Fanyana, Hotapa, Clinic.
Oh,
that's the only thing about
okay. I born again, needs shampoo. Needs shampoo. Okay,
yeah, the shampoo is out, Capaccio, never Musilion.
Mamma, Dr. Slova, I give Professor Yatsona Tabas, what else exactly what is happening now. Clearly, this is tinea capitis, and you know notoriously that if you treat it with these shampoos and other ointments, it doesn't really go away. Most of those patients will need to take some form of systemic treatment, some tablets that they must take. Especially this one now, it has gone a little bit septic because ordinary boladunyalo, so it's gone septic. What treatment would you advise?
How old was the patient?
15 years.
15 years.
Yeah.
Okay, I just want to add to the caller that tinea capitis, which is fungal ringworm, that's what it's trying to describe, normally occurs in children. Okay, so it is possible that it's unlikely that she's dealing with tinea capitis, because tinea capitis in adults occurs only in the setting of HIV or immunosuppression.
So at 15-year-old, it might be other things.
Could be seborrheic dermatitis, eczema of the skull, could be psoriasis of the skull, could be something else. But be that as it may, if it is tinea capitis of the scalp, you need systemic treatment tablets, as you have mentioned. The shampoos and ointments won't work. When you treat fungal infection of the hair and nails, it has to be tablets. But the creams definitely won't touch the disease. Yeah.
But the best advice is that atsamai a lo bona
Must go and
dermatologist,
see a
because
skin
clearly if another
specialist, yeah.
something is a bit better, tshwantse go tlele ko tleliniking o ikokobetse mme o re kopa ba romele ho skin specialist tse tshwanang le bo Dr. Jova le Professor Mosamo mona, because those are the only people who now can make a proper diagnosis, or maybe take a piece ya seso se se hlaile ba se romela ko laboratory, make a proper diagnosis, ha se re tseba hantle hore bothata ke, then we can give the proper treatment. Ya finder ya zama ntse ba etsa clinic mon ba bapala ka ngwanono a ke ba mfe treatment ya proper. We'll continue our discussion on HIV and the skin after the break. Welcome back. One is o sa tswela pele ka hlosa letsatsi mona Bonitas House Call with SABC 2. Lenane o lo utlwisetsang ngaka ka tlung. And today we are talking about HIV and the skin. Now let's continue to look at some of the pictures that appear in this book, beautiful book that has been authored by my two guests in the studio. Now this condition that we're going to be seeing now, Dr. Clover, I've seen this many times also. People wearing sandals with this kind of thing.
On the beach.
Yes.
Yeah, this is fungal.
See them on the beaches.
Yeah.
Yeah.
This is fungal infection involving the nails.
I see.
Now, the question is, does it mean when you have fungal infection involving the nails, you've got HIV? No. But if you've got more than one nail involved, that then there's chances that it is HIV related. So if more nails are involved, you're probably having HIV. And it is treatable. You need to take tablets for a long time though, and it's quite expensive. So it's better to come early for treatment. Don't ignore it and say, oh, your nail has been traumatized about something, because it can also spread to the skin, involve your groin, involve your scalp, and involve your body. Then you get infection, fungus spread into the whole body.
I see. So when you see it, ordinarily, you don't worry. If it involves more than one digit, you begin to suspect that there could be underlying HIV condition.
Yeah.
And then you test for
Yes.
HIV,
For HIV.
and then you
And I
treat.
think the important thing is we very often see patients who are misdiagnosed as a fungal infection. So psoriasis, there are many other nail conditions, and very often patients are put onto antifungal therapy, which is expensive, and there can be problems with it. You can have hepatitis. So a nail culture has to be taken to diagnose the fungus before one starts. 3 months, you commit to a tablet that's expensive for 3 months. So I think that's important, because if you've got psoriasis of the nail or other conditions, it could
So it's important to make a diagnosis, take a
diagnosis
scraping of the
and
of
send
the
it
nails,
off to the
send it
laboratory so
and
that
know
you've
what they're treating.
diagnosed that, yes.
This condition, Dr. Love, this is the tongue, hey? So what has happened here?
Anissa, give that to
All
you.
right,
I know you
okay,
like
so
tongue
that's-
infections.
What is this?
Okay, so that's candidiasis. It's one of the very common manifestations of HIV, probably the commonest associated with HIV. That's
So this is
another
a
variant
thrush,
of it.
yeah.
This is all thrush, yeah. Very common in the mouth, and that's very important for people to look at the mouth, you know, when you're examining patients. Patients come in with, you know, these cottage cheese-like curds that occur on the mucosa. You know, that would be in keeping with the diagnosis of candidiasis. Very easy to treat with topical antifungals, and if that doesn't work, then systemic medication can be used, like fluconazole.
At
That's
what
very good.
stage of the HIV disease
Yeah, I was
do you
just
get,
going
do
to
you-
say
do you-
that,
do you get this condition?
Now,
happening?
oral candida can occur early, and it can also occur in advanced HIV.
It can occur during the seroconversion stage, when the virus is beginning, as we
Well,
said
not
earlier.
seroconversion, but the early stages where you get herpes zoster and other fungal infections. And then it can occur at the late stage, where now, instead of being localized to the mouth, it actually goes down, and it involves the esophagus,
Yeah.
and patients present with, you know, inability
difficulty
to
in swallowing and
swallowing,
all that,
yes,
yeah.
and painful mouth. And they
Now,
can also
this
have
one
vaginal candida
Also
at
can
the
get it
same
also
time.
in other mucosa,
In
like
other
in the
areas.
vagina and other places.
Yes.
Islonda lis. How about it? This is just an ordinary slonda. Or what is this?
It's eczema. It's a type of bacterial infection one can get. Now again, I think, you know, we had mentioned this earlier, that in HIV, generally the skin conditions are what we see in the healthy population.
And
so
we need
the
to emphasize
infections,
that. Yeah.
so, and predominantly they are the infections, the fungal and the viral infections. However, when they occur more severely, when they're more recurrent, that's when we need to, consider HIV. So you are going to see, so I think when we're training doctors, we're training them to diagnose infectious and inflammatory conditions. Those are the same ones that occur in HIV. It's just that we need to be aware if they're not being treated effectively, they're more severe, they occur in atypical sites, they occur in an age group that shouldn't be getting it, for example, tinea capitis in the adult patient, that needs to alert us then to do HIV testing. And then the treatment is the same. The treatment is as you would treat it,
in an ordinary
yeah.
This one, Dr. Lo.
Yeah, this is a very challenging condition for any skin specialist. It's basically many plain warts. We call it EDV, but you get
These are warts?
These are plain flat warts, yeah. And you get them in sun-exposed areas, and they are extremely difficult to treat and really cosmetically a challenge for patients, yeah. And they also tend to occur, more in advanced HIV, yeah.
Now, we spoke about herpes zoster. Now, let's just clear this thing. Now, herpes as a condition, what is herpes and what are the various types? Because we also know that in the mouth, you can get herpes. In the genitals, you can get herpes.
Yeah.
And how does this present in HIV patients?
I'm glad you asked that question. Now, herpes, there's about many types of herpes virus. But if we want to focus on herpes type 1 and 2, that is herpes simplex virus, what the layperson calls fever blisters. Okay, now
that's herpes simplex.
That's herpes simplex.
That's a fever blister.
Yeah, type 1 is the one you get around the mouth, fever blisters. Type 2 you get in the genital areas.
Wait, now don't rush. Now, fever blisters, it means you first get herpes, it heals, and it sits around the mouth, and every time your immunity goes down, it erupts.
It erupts, yes.
So do you therefore mean that people who have a fever blister, it almost appears at the same spot because that's where the virus is hiding?
Well, not necessarily at the same spot, but it may occur around the same area, around the same, so it could be in the mouth or outside around the lips. But herpes simplex, the important thing is this, it tends to be recurrent. It comes back, it heals and it comes back. You can get 8 attacks per year, you can get 6 attacks per year, it varies. But with HIV, there's a variant we call chronic hepatic ulceration. Once you have that little sore and it goes on for up to 3 months and it doesn't heal, then that signifies AIDS. Okay. That is serious.
Now, herpes in the genitals, now, is that a different one?
So that's basically the same herpes simplex virus. There's a type 1 and a type 2. And the type 2 is usually, so they both are herpes simplex viruses, but that generally occurs in the genitalia in most cases. However,
now, if there's contact between the mouth and the genitalia, which
so
sometimes happens, so you can get this other one going this way and this other one going that way.
Yes. But the good thing is that they're treated in the same way, even if we don't know absolutely the type. So we can get type 2 in the oral mucosa as well. They treat it in the same way.
I see.
And I think the important thing about diagnosing herpes is that it's painful. So it's the pain that's important and the recurrence. One can diagnose it very easily and treat it with antivirals.
So if you've had it in the genitals, it's likely to come back and come back.
Absolutely.
Yeah. And once you have the vesicle, the blister, and it's intact, and the ulceration, it's highly infectious.
I see.
So people should be using condoms to avoid, it's actually the most common sexually transmitted infection, that is herpes simplex type 2. And just to add to what Anissa mentioned, the important thing is if you don't have HIV, it heals. Within 5 days, a week, it heals.
But it will come back.
It will come back. But with HIV, it tends to stay there for longer and crust forms ulcers and very difficult to heal.
That's all the name. I guess we begin to get in the way. Uma ngabe uphethwe yibhandi noma ishingles vese unengculaza akulona iqiniso futhi ke into ofanele senze ukuthi ukuthiwa masimhlazana leli bhandi lihlangana usho ukuthi icimiyani sohambile kuyinsumansumane ngempela ayikho into enjalo kodwa siyathanda ukunxusa bonke abantu abanebhandi balana eNingizimu Afrika ukuthi ake bahambe bayothestela isifo sengculaza noma isandulela ngculaza. We'll continue and round up our discussion on HIV and the skin when we return. You're watching Bonitas House Call here on the SABC2, and welcome back. Dr. Slova, where do we get this book, and what is the key message of today's?
Well, the book is available from the department, and it's really aimed, as you mentioned, at doctors, GPs, nurses, and
what do you mean
healthcare
from the
workers.
department? From the Department of
From
Dermatology,
Department of
University of
Dermatology.
KwaZulu-Natal?
Yeah,
Oh.
your alma mater.
My alma mater, Congela, Umbilo Road to
Congela.
Congela. Oh,
Yeah,
okay,
you can phone
beautiful.
the secretary. In terms of my take-home message, I'd like to say this to the viewers. Firstly, 9 out of 10 people with HIV will present with a skin condition at some stage of their HIV disease. And 30%, that is 3 out of 10, will present with a skin condition. So it's important to be familiar with the various skin conditions, because the skin is so visual. You can actually tell tales from the skin. The second thing I'd like to say to the viewers is that, yes, we respect traditional healers. Yes, we've got cultural beliefs. But when it comes to HIV, go see your medical doctors, because the earlier you present, the better it is for us to treat you. And the last thing is, if you start ARV treatment, do not stop the treatment because you are feeling better. HIV is not a death sentence.
Once you have the condition, it's a lifelong treatment.
It's a lifelong.
Professor
yes.
Masam, your key message.
Okay. I think we've come a long way from where we were, with the huge burden of HIV that we see in South Africa. And, in terms of our National Department of Health, we now have the largest ARV program in the world.
Indeed.
We've made huge strides in terms of prevention efforts as well as treatment efforts. But with that treatment, we need listeners and viewers to know that sometimes the skin gets worse, and we call this immune reconstitution. So very often, up to 30% of patients, especially in that first 6 to 12 weeks, might actually be getting worse. So they need to come back to their doctor, and especially skin conditions like the viral infections and bacterial infections will worsen. They need to adhere to their antiretroviral therapy and get treatment for those conditions that might worsen initially on antiretroviral treatment.
Professor Mosam, Dr. Slova, thank you for making the trip all the way from Devon to come and join us this morning. We really appreciate your time. And I want to pass the message of thanks to your families as well for allowing us to join us this morning. Have a safe trip back to Devon, and thank you very much for enlightening us. So this book is available from the Department of Health or Department of Dermatology in the University of KZ and my alma mater. Banabes, rona bohle barati, ba tshehetsi, ba thaseli, ba khothumetse ka siterane ba manukeng ba lanoleng. Nnete ke ya moroho le tswa ke baki. Science rona he letsatsing la kanje. We'll be back next Saturday with sudden death in young men in South Africa, something that has troubled us for quite some time in the recent months. So don't miss it here on the SABC2 at 8:30 in the morning. Thanks for joining us today. From me, Dr. Victor Ramathesele, You take care.